Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending our fourth and last session of this Learning Collaborative Implementing the Smoking Cessation Program in Health Centers. At this moment, this is a live session. All lines are muted. If you have any questions, you can use the chat box, type your question, and then we are going to have a Q&A after Frank's presentation, or you can also use the raise hand icon and your line will be unmuted if you would like to discuss this, any questions verbally. The National Center for Health and Public Housing is a national training and technical assistance receiving federal funds from HRSA to provide training and technical assistance to community health centers. What you are about to hear and what you are about to learn is not, it doesn't represent HRSA's points of view. So this is solely the recommendations from the National Center for Health and Public Housing. Before we get started, just a quick review regarding public housing primary care. In 2019, 108 public housing centers reported to be public housing primary care grantees, and they provided services to over 800,000 patients. In addition, 433 FQHCs are in or immediately accessible to public housing, and in 2019 they offer services to over 5 million patients. Just a reminder, these are the demographics and all the social determinants of health affecting public housing residents, but I would like to highlight that 93% of them are under the poverty line. 38% of the household report to have at least someone who is disabled. 35% of them reported to have someone who is older than 65. 52% of the population living in public housing are white. 37% are children under the age of 18. 25% are Hispanic. 43% are African American. And last month, HUD reported to have 1.7 million people living in public housing. In regards to smoking, the HUD and the Center for Disease Control and Prevention put together a publication, a health picture of HUD-assisted adults 2006-2012. And there was information about the number of, the percentage of those living in public housing who are smokers. And then as you can see the graph here, over 33% of those living in public housing are current smokers. Just a reminder, all the materials for this learning collaborative are on Moodle. You received the link if you haven't, and if you would like to access any of the resources or any of the materials that have been provided in the past sessions, just contact us, and then we will be happy to send you the link to the Moodle so you can get all the supporting documents. And I am now turning the presentation over to Frank Vitale. Good afternoon, Frank.
Good afternoon. Thank you so much. All right, so I am going to review the, oops, it's the wrong one, the protocol that we have been looking at the last few weeks. Okay, here we are. And get to, okay. All right, so as you remember, this protocol calls for 6 sessions to help the person quit smoking. By the way, if you can't see this, please let us know. I'm assuming you all can see it. So we did the first 4 sessions. We reviewed what to talk about in those. So we'll finish up today with the final 2 sessions. And you can kind of look at this in this protocol in 3 parts. The first 2 sessions are kind of getting ready to quit. The middle 2 sessions are quitting, and then these 2 sessions we're going to focus on staying quit. So what does the person need to be able to stay quit long term? What are the issues that they're going to be dealing with, and how can we help them get ready for that? So as with all of the sessions, I do recommend that you begin each one by asking the group to tell you what the last week has been like for them. And I really like to go from this perspective of wins and challenges. So I like to use those 2 words, and because I think it puts it in a more positive light. So what worked? Let's start with that with our people. What has been working for you? What are the successes? And then review what the challenges are. So take as much time as you need to deal with all of this with the individual group members that you have. Then we're going to talk, and I have this in here in all these last 3 sessions, about slips and relapses. So even though we are going into this with our hope that everybody's going to quit, the reality is that some people are going to have slips, which means 1 or 2 cigarettes in a very specific situation, and other people are going to relapse back to a full-time pattern of smoking. So you need to deal with that. So one of the things you need to determine at the beginning of each group is everybody's status. And the best way to ask that question is, how long has it been since you had your last cigarette? Don't say, are you smoking or not? Because some people who have a slip will say, well, I'm not smoking, because they're not doing it on an everyday basis. So the question at the beginning here is, when did you have your last cigarette? And hopefully everybody will say on their quit day. But if you have somebody that has a slip, deal with it this way. So a slip, again, is just having 1 or 2 cigarettes in a very specific situation. Now, what happens here is the person starts to immediately label themselves as a failure, or that they're weak, or that they can't do this. So I would suggest you approach this from this perspective. Ask the person how many cigarettes they smoked a day. So let's say you have somebody who said they had 1 cigarette at a bar, the day before, and then they tell you that they used to smoke 20 cigarettes a day, and they haven't had any cigarettes at all other than that since quit day. So it's been 3 weeks. That's 20 cigarettes a day. So, that's well over 300, 400 cigarettes that they did not smoke. So help them understand that if you look at it from this perspective, you didn't smoke 400 cigarettes, you only smoked 1. That's 399 out of 400. And on any test, that's what? An A. So you're not telling them that the slip is okay. What you're doing is refocusing them on the fact that they quit and have been successful at that. Do not say to the person, oh, 1 cigarette's no big deal. It isn't, but if you use those words, if you say that, what have you just done? Well, you've given them permission to continue to smoke. So this is about refocusing them onto the fact that they've been successfully quit for a couple weeks, and then you can look at what happened that led them to have that 1 or 2 cigarettes. So you want to get them out of that failure mentality, because if they stay there, it's just going to whirl around in their heads, and they're eventually going to start to say, well, I'm weak, I'm no good, I can't do this, blah, blah, blah. That will eventually lead to a full-blown relapse. So look at what the issue was, and then discuss how they can cope in that situation should it happen again. And here's where you can use the group. So you could say to the group, has anybody else had this experience? And if they did, what worked for you? So this is a really good way to engage the group to help the person. Now, I've given you a handout for slips and relapses that you can give to the person that they can use to help them get a better idea of what had happened. Now, with relapse, that is back to a full-blown pattern of smoking. So it's very similar, but you need to go into a little more depth here because they're back to smoking full time. So the question here is, what else could you have done in that situation that led to the relapse other than smoke? So really help them understand that there are alternatives, that there are other ways to deal with this. And again, turn to the group. Has anybody else experienced anything like this? If you did, what did you do? And now it's entirely appropriate, even if the person has come to the group and they're still smoking because of the relapse, to ask them, when do you want to set your quit day again? And really encourage them to do that. Now, they may be in a situation, let's just say they have a son that ended up in the hospital, he's in critical condition, and they're having all these issues. So this may not really be the right time for them to go back, but don't let it drop. I would set up some kind of follow-up with this person so that you can then help them set another quit day when things have settled a bit. But generally speaking, there really isn't any reason for them not to set a quit day. And you really want to focus this on as a learning experience. So, what did you learn about yourself? What can we do differently? All those kinds of questions really help here. Now, in both cases, whether a person has slipped or relapsed, unless they're back to like smoking a whole pack a day, you're not wanting them to stop using the medications that they are using to help them quit. 1 or 2 cigarettes certainly isn't going to hurt anybody on any of the medications. And unless, again, they are, and you have to, this is a judgment on your part. I mean, unless they're smoking back up to their regular pattern and they're just telling you they don't even want to try again, then I wouldn't stop the medications because there really is no real reason to do that. So the other thing you want to do with individuals, all the individuals in the group now, is to review their medication use, make sure that there aren't any questions about it, and make sure that they're all using it correctly. Okay, so that slips the, yes.
Frank, let me interrupt you for a moment. We have some comments here.
Okay.
There is one saying that there is the challenge was maintaining regular attendance.
Okay.
And the other one is that using the nicotine patch helped one of the person who quit it.
Does the nicotine patch help somebody quit?
Yep.
Is that the
helped. It's a comment is that this person by using the nicotine patch help this person to quit.
Oh, okay, okay. So attendance, I addressed that right at the beginning of any kind of program by asking the person to commit to you to come to every session. I think you need to state that up front. The only way this works well is if you come to all the sessions. And if there are barriers to that, then you need to help the person eliminate those beforehand. So I just addressed that really up front, immediately at the beginning, when you're negotiating all the dates and everything with them. And especially if it's a group, you're all committing to do this. It's only 6 hours in your life. So, there shouldn't be too many reasons why you can't come. Now, of course, if something happens unexpectedly and you're able to do it, you can make up the session with the person individually. And you can even do that by phone. But yeah, it's something that I really, really, really emphasize at the very beginning. So I think if you do that, it's less likely that you're going to lose people. Now, the other issue is somebody may start to smoke again, like we're just talking about here, and they figure there's no point in coming. So I always say to people at the very beginning, no matter what happens to you during the time you're with us in this group, I want you to come to the group. There is a benefit for you to come no matter what. So I don't actually say, well, if you relapse or have a problem, because that kind of plants the seed in their head that it might happen. Just say, no matter what is going to happen, no matter what the situation is, I want you to commit to coming to the session. If you really feel somebody is not going to actually commit to do this, or you know this person in the past, then you may want to actually get them, write a contract with them. Just very simple. I put the name, commit to coming to the smoking cessation group on these dates, and then have them sign it. That kind of makes it a little more real. So I've done that with individuals many times. And the other issue, the other comment was that using the nicotine patch, absolutely. So the whole point of this, again, I will emphasize this, and I've said this at all these other sessions. There are two parts to quitting, so there are two parts to smoking, so there's two parts to quitting. It's a physical addiction to the nicotine and a behavior. So what I'm talking about here is dealing with the behavior, but we also want everybody to use one of the medications, because we know just using one of those medications in conjunction with doing this doubles their chances of quitting successfully. So there's no reason not to use them. And as far as if somebody telling you they cost too much, right now, on average in the United States, a pack of cigarettes costs close to $7. None of the over-the-counter medications, the patch, the gum, or the lozenge, cost anywhere near that a day. So if you can afford to smoke, you can afford to quit. Okay, hope that helps on both of those comments. Thank you, by the way. So keep, any comment, any question, please don't hesitate. All right, so the focus of the group today, once you've gotten through all this, is then to help the people start to look at what they are getting from quitting rather than what they are losing. So the whole point is to start to look at the benefit of quitting, because what happens here so often is that people get stuck in this, I lost something very important. And they did in many respects, in their own thinking. Cigarettes had a very important place in their life, so they have lost something. But it's time now to start to focus on what did you get. So you want to talk about better health, more money, improved relationships with family and friends who may have not liked the fact that you smoked, self-esteem. Many people at this point say, wow, I feel so much freer. I feel so much more in control of my life. So help each person in your group identify something that is positive about this that they can start to focus on. At the same time, you want to review the coping strategies that they're using and make sure that everybody is employing them. Again, we can talk about these things forever, but if you don't do them, there's no, when you're out of the group, they're not much help. So, really emphasize that. Okay. And then as usual, end the group, with congratulations and let them know that the following week will be the last meeting. Now, again, as I said at our first session with this, I normally structure it this way. This seems to be the optimum number of sessions people need without getting into too much repetition. This seems to be the optimum number of times somebody will come to a program. But if you feel that an individual or a group wants to meet more, there is absolutely no reason you can't do that. If they need the extra support after this last session, then that's fine. And what you do then is you just structure that as more like an AA meeting kind of thing, where they're all coming together to support themselves. I've had groups that have bonded so well and liked each other so much, they would come in for months after their last session. So that isn't something that is necessarily that unusual. And if you can't do that, and that because of your work restrictions, they can certainly meet on their own. There's absolutely no reason that they can find a space and they can get together and continue to help each other. So offer them that if that's something that'll work for you. All right, so the final session then is really looking at preventing relapse. And what do you need to do to keep this quit going? So again, you deal with the wins and the challenges. Then you look at if any relapses or slips have occurred. So that's just a repetition there. And then the focus, the theme of this particular session is to prevent relapse. So I want you to look at 3 words: anticipate, plan, and rehearse. So you want to talk to the group about what situations that are coming up do they anticipate to be problematic. Use real situations, and then what you want to do is create a plan to deal with that ahead of time, and then practice that, your response, your way of coping before it happens, so that you have that tool ready. And a group situation is perfect for doing this because you have other people to do role play with. Okay, so do as many of these as you need to help the persons feel comfortable, and really, ask them, okay, in the next month or 2, is there anything coming up that you think will be a problem for you, where you might be tempted to smoke? And somebody might say, well, I'm going to a wedding, or my mother's going in for an operation, or whatever it is. And then you can work with them to help them create a plan. Then I want you to transition into all of the other things that they can be doing to keep the quit going. And that revolves around lifestyle changes. So if at this point you see that somebody is having concerns about weight gain, then I would refer them to appropriate individuals. If you have somebody within your clinic that deals with that, Weight Watchers group, anything like that. So this has now been like a few weeks that they've been quit. I really don't recommend that if somebody's concerned about weight gain, that they really even try to tackle that until they've been quit a good 2 months. We know from experience that if you try to make 2 major behavior changes at the same time, they generally fail. Both of them fail. So again, if they're concerned about weight gain, then this is something that they can address in the future, and you can give them the resources to do that. I would suggest that you get everybody into some kind of walking program. Exercise, the word exercise scares a lot of people, but walking doesn't. So I would bet that 99% of the people you're going to be dealing with don't even walk very much. So I would really suggest that you start with that, get them walking like half an hour, 45 minutes a day. If they want to join a gym, they now have extra money to pay for that because of the fact that they're not smoking. So they're saving a lot of money. So that may be something that people want to use. So really encourage that. The more somebody exercises and the more they get involved in healthy lifestyle behaviors, the less likely they are to want to go back to smoking. So focus on those 2 things. And then the third thing is stress management programs. So if your clinic offers something like that, that may be a great way for these people to transition into something that will give them extra support, but isn't actually the smoking cessation group. So if you do something like that, if you have a meditation group, a yoga, Tai Chi, anything like that, talk to the people in your clinic that do that, and maybe work a system where you can then refer everybody once they've quit into that kind of program. Again, reinforce the benefits of quitting. And then, the next bullet point here is to look at long-term support. So what kind of support are they going to need to keep this going? both in terms of people in their life and other programs, other other support systems, support programs. So each individual person will be different. So you want to check at this point to see what they will be needing. As far as the medication goes, then you really want to talk about here about how they're going to eventually get off of it. So depending on which medication they're using, you will want to look at either tapering or when they will be done. My caution here is don't let these people stop too soon. That's the problem. It's not, we always worry, or we think the problem is going to be people are on this stuff too long. Oh my gosh, they're going to be on the patch for a year. That very, very, very rarely happens. The real problem is they don't use the medications long enough. So again, discuss that and make sure that each person has a plan, a very thought out, concrete plan on how to get off the medication at the appropriate time. If you want to do other sessions, again, we just talked about that, do that. If you want to do individual follow-up by phone, and there's a million ways to handle that. But so, whatever works in your clinic, whatever works in your situation is perfectly fine. Now, I normally do not suggest that you allow food into the group, but many times when I've done these groups, they want to have a little celebration on the last day. So that's perfectly fine, I think, if they want to bring in cookies or cake today and have some soft drinks. This is not necessary. It's not something you have to do, but if somebody wants to do that, I'm perfectly fine with that. So those are the 6 sessions in detail. So you have this to go by when you're actually doing the sessions. Those are the specifics for each one of the sessions. What I want to finish up here with are some of the general suggestions I have for conducting the group. And again, if you're doing this individually, just obviously tailor this to the individual person. So a group generally, from my perspective, should not be more than 10 people. It just gets to be too cumbersome, and it doesn't really work if there's more than 10 people. And I really do this where everybody is sitting in a circle facing each other. So it's not like a classroom. It's more of like a group therapy kind of milieu. Each session, about an hour is generally good for each session. You may need more for the first one because people are introducing themselves and just getting used to everything. So an hour and a half is fine. Only the people in the group can attend the group. No support people, spouses, and no children. I know some people may have problems with childcare. Deal with that, get that all worked out beforehand. Children will destroy the group. It just won't work. First of all, they'll make a lot of noise and they won't be, they'll be bored to tears. But there's a lot of stuff you're going to be talking about that may not be appropriate for children to hear. As I just said, I do not encourage food in a group. You can go an hour without eating. If you want to bring in a glass of water, a cup of coffee, that is fine. I have no issue with that. But again, try to keep this as professional and as real as you possibly can. Now, from your perspective, I want you to always approach this with a positive attitude. I go into every session with every person assuming that they're going to quit, even though rationally I know that that's not going to happen. But I really think your confidence and your belief is transmitted to the individual or the group. So you really want to approach every session you do from a positive perspective. As such, you want to avoid using a lot of these emotionally loaded words here. People tend to put quitting into that perspective anyways on their own. So I don't think it's really helpful if you use words like, horrible, torture, agony, all that kind of stuff. I also don't want you to say to anybody, it's hard to quit. I'm not saying that it isn't, but think about this. You're the authority figure here. If you use those words, what the person really hears is, I don't think you can do it. So what I want you to focus on, I use the word, it's not a real word, but it's doability. It can be done. Everybody can quit. Any smoker can quit smoking. It's just a matter of figuring out what the right way is for each person. Okay, so that's kind of the general attitude for you to go in. From a very practical perspective, please be aware of time. If you let people talk about themselves, they will take hours and hours and hours. So you really, part of your job here is to limit while allowing them to say what they need to say. So you'll get good at that. You'll be able to monitor that and know, when it does seem to somebody's rambling on. On the other hand, there are people who are just going to sit there and not say anything. So again, with those people, your job is to draw them in and make sure that they are part of this. Keep it light. It's serious, but this doesn't have to be, like dead serious. Be upbeat. But I also want you to realize that for many people, this is one of the most important things they've ever done in their life. So be respectful of that. I like to put this in all the time because especially when you're first doing this, many people think that they have to be nice and that they can't challenge anybody. So that's not the case. Your role here is not to be nice. Now, that's not to mean that you have to be nasty or angry or chastising people, but it's okay to say to people, I feel like you are being very negative here, or I see you doing blah, blah, blah. So you don't have to necessarily agree with everything, but part of your role here is to be, like up above observing what is happening. And that is not only what is happening to the person outside of the room, but inside the room. There may be some behaviors that are going on within the group itself and within the people in the group that reflect the issues they have around smoking. So again, this may seem kind of scary at first, but as you do this, you'll get better and better at seeing this. Remember, the group is not about you. Leave your issues, your problems outside of the room. When you walk in there, just pretend like everything else outside is gone. Because if you are not focused on the people, then they're not going to be able to focus on themselves. The most important skill here, I think, for you is to listen. When I learned how to do group therapy, I remember my professor telling me, he said, when he's talking about himself, said sometimes when I do group, I don't say one word. I maybe just welcome everybody and initiate the conversation and just let it go. So don't necessarily think that you have to be talking all the time. The whole point of the group is for everybody to help each other. So don't be afraid to be quiet. Okay, so that, I know this is a little shorter than the other sessions we have, but I think we've pretty much covered everything that we need to for the group. So now what I'm hoping here is this. I know the holidays are coming up, so it's probably going to be pretty difficult to do anything. But a lot of smokers like to start the new year quitting. So this may be the time right now to start to advertise a group to start at the beginning of the year. I guess it's a perfect time to do it because of that. So I would really suggest that you all start your first group in January sometime. And as such, I will be available. So you have my phone number, you have my email address. You have Dr. Leon's contact information. So once you get started, if you have any questions, any concerns about the content, about how to, run the group, about, how to do any aspect of it, or if you have a question about an individual patient, part of my agreement here, part of my deal, is part of my, what I want to give to you is myself as a resource. So please don't hesitate to call me, contact me when you get into this with any questions. I want to be there to guide you, through this as much as you need. So don't hesitate to do that. Okay, so we have plenty of time for questions. This is the time now to anything about any aspect of this that you want to ask. Please feel free, and we will go from there.
Thank you, Frank. Thank you. That was a great presentation. Again, if you have any questions, any comments, anything that you would like to discuss with Frank, you can use either the chat box, or you can use the hand raise icon and your line will be unmuted. Thank you, Frank, for the last few weeks that you've been with us, providing your expertise and everything that you know and that you are familiar with, to share with the health centers and those who have been participating on these calls. I would like to remind the attendees that 90 days after this session, we are going to get back to you to see if you have been able to implement these strategies, or whether you have been having some challenges, or if you would like to share with us some best practices. In the meantime, as Frank said, do not hesitate to contact us. You have my contact information, you have Frank's contact information, and you can also send emails to the National Center for Health and Public Housing, info@nchph.org, and we'll be very happy to hear from you and help you if you have any questions, any challenges, or just the fact that you would like to share some of the information or some of the best practices that you have in place. So if you have questions, this is the right time, the right moment to, now that we have Frank here live, so do not hesitate to contact, to either type your question or just ask your question verbally.
Yeah, and on any aspect of quitting or smoking is fine.
And there have been many health centers asking for additional training on this particular topic. So Frank will join us probably next year to develop some more content, so stay tuned. We are going to provide you are going to be the very first ones to receive any update on any other training that we are going to put together on a smoking cessation or any related topic. Let's see, Frank, if we have any. I don't see any additional Frank.
Okay.
Frank, regarding the challenges to, and just following up on the comment that we got regarding how to keep your group, attending all these sessions, and it's my understanding that sometimes patients, cannot attend because they do have they can have an emergency or a personal issue. So how stringent you need to be, with your patients when there is an issue like this one?
Well, that's a very good question. So I guess I want you to, here's what I do. I give them the impression at the beginning that it's very stringent and very serious, and that they have to come, so that so that it kind of creates that expectation. But the reality is, as you just said, things happen, and I know that. So when they do occur, you just deal with it. You figure out how to make up the session. And again, when I did this, a big NIH funded program where we were running groups all the time, I would just follow up with individuals on the phone. So if they couldn't come to the group, then I would meet with them individually on the phone before the next session. And honestly, if you really create the expectation that they have to be there, and you're creating an interesting, inviting atmosphere in the group, they will come. Unless, again, as you say, unless there's an emergency or something happens, and then we just figure out a way to make up that meeting.
Excellent, thank you, Frank. And there is a question, let me read this. This is from Barreto. The previous were comments. This is my question. I have some people who use smokeless tobacco and was using nicotine patch before. I talked to him. What advice do you have on how to help him better?
Okay, so that's a good question, because the patch is not indicated on the box, for smokeless tobacco, but I have used it many, 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 many times. The issue here is that most smokeless tobacco has way more nicotine in it than a cigarette. And because they're leaving it in the mouth, and they are getting a constant supply of nicotine all day long. So the problem with the medications is that you're not using enough. So my recommendation is anybody who's using chewing tobacco wants to quit, put them on the 21 milligram patch and give them the 4 milligram lozenge. They use the patch as indicated, and then they use the lozenge as long as they need to give them a bit more nicotine throughout the day, when they're in a situation where they're having an urge. So I've seen that combination work really, really well. We know that's safe. We know it's effective. So that's number one. Number two, if you look at all of the coping suggestions that I gave you in that coping menu, you can use all of those. Again, chewing is just as much a habit as smoking. So help the person figure out when they tend to use it the most, when they put a new chew in, what's going on, what is happening, and then help them understand that there are other ways to deal with those situations. So somebody might say to you, well, I go fishing once a week and I always use chew when I go fishing. Well, maybe skip a week, go to a different fishing place. Instead of fishing on the boat, fish on the bank, or the other way around. Change it up as much as you can. So no matter what it is, no matter what their pattern is, there are ways to break that up and change that routine. So I know these are successful because I did a big project with people a lot of them who used chewing tobacco and snuff, and it worked fine. So again, using more of the nicotine replacement therapy rather than less, and then actually looking at their pattern of use and then helping them break that routine.
Thank you, Frank.
Also, the big thing people miss who use chew and snuff when they quit is having something in their mouth. So there is a company that makes it's a substitute for chew, but it's mint. It's just mint leaves that are shredded, and they're in like a little packet, like a tea bag. So that's a nice substitute because mint's mint. There's nothing in it that's going to hurt you. and it just gives you that sensation of having something between your cheek and your gum. Other than that, sunflower seeds, very pungent. There's some old-fashioned chewing gums that many people who are quitting like because they have a bitter taste and it kind of reminds them of the tobacco. Tea berry, I don't even know if they still make these things, but I think they do. But we found sunflower seeds to be a good substitute. You know, just a lot of ball players do that now. You see, they'll keep a couple sunflower seeds in here and then just every so often, you know, pop one up and chew it and eat it. So yes, so oral substitutes are a big issue for chew users. That is not necessarily a problem for smokers.
Excellent, thank you, Frank. Just a reminder, this is Frank's contact information. If you have any additional questions, you can also contact Frank directly on any challenge or anything that you would like to share. Just send an email and he will be more than happy to reply to you. Ida, do we have any additional questions?
No questions at the moment.
All right, so on behalf of the National Center for Health in Public Housing, I would like to thank all of you for attending this Smoking Cessation Learning Collaborative. Again, we are going to have something on smoking cessation by next year, so stay tuned. In the meantime, please visit our website. You will find information on other activities, other training topics, and anything that you need in regards to helping your populations on any of the chronic medical conditions that are affecting all the people that you serve. You can also join our mailing list, and you are going to get information on HRSA's funding opportunities and other resources, and as well as information on upcoming training and webinars. And this is our contact information. You can contact me directly as well. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. And again, thank you so much for your time. Please complete the post survey, and we are going to get back to you probably 90 days after this session, just to so you can share some challenges or best practices. Thank you so much again, Frank. It's been a pleasure to.
You're welcome.
Sure, and
Happy
thank
holidays, everybody.
All right. Take care and have a great day.
All right. Bye-bye.
Bye.